Hi, this is Brian Kim. I want to share with you case number 216 in the Best Way to Do Cataract Surgery series. This is not a terribly dense lens, but what you'll notice is this lens doesn't want to spin. And so that could be a variety of factors that cause that. You can have loose zonules, you can say ineffective hydrodissection, or just a sticky nature of the lens. Nonetheless, when you have a lens that doesn't want to spin, you can just push on the zonules and damage the zonules, or you can find other methods to disassemble the lens without spinning the lens that doesn't want to spin. And so you're going to see how I do that. And so you're going to see what I'm able to do in this lens that doesn't want to spin. So this is a corneal marker, which will help me to center and size the rhexis. And this is my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. Using the cannula to control the eye, this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, and then I enter. Again, I'm using the cannula to control the eye. This patient has a Bell's reflex. This is the left eye, trying to control the eye and turning the eye down a little bit with the cannula. This is the Moria microrhexis forceps. I puncture the center, pull down, grab the right side of the tear, going around circumferentially. I'm trying to make the rhexis about the size of the corneal mark that I made. Going around circumferentially, I have that cannula for two purposes. Remember, I'm using it as the orelock to control the eye because this patient has a strong Bell's reflex. But if I start to notice instability in the rhexis, I can also push OVD to stabilize the rhexis as well. So again, try to consolidate your instruments and your maneuvers whenever you're doing surgery. And this is the capsule fornix hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, lifting the lens up, decompressing the bag, sweeping underneath the rhexis edge under the left side and then the right side. You can see here I'm trying to spin the lens, and this is often what happens. This is a lens that has very soft material on the exterior, the epinucleus and cortex, and it doesn't want to spin, partly because of the soft material, but also because it's still stuck to the bag, despite a good hydrodissection, and despite me lifting the lens up. So go ahead and lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Place the chopper under the rhexis edge contra-incisionally, defecative vertically, subincisionally. Fracture the lens completely in half. That's double chop, placing the chopper around the right heminucleus, hooking the peripheral lens, crushing the lens in half, and that is the cross chop. Using some vacuum to lift that first quadrant up, crushing the lens between the instruments and emulsifying the lens piece. You can see here when I performed the double chop, there was no translational movement to the lens. There was no stress on the zonules or the bag whatsoever. I was able to use opposing forces to just crush the lens in half. Loosening up that second quadrant, grabbing it and crushing it between the instruments and then emulsifying the lens piece. And so this is what I'm talking about. This lens is stuck. Well, guess what? It's no problem. I placed the chopper under the rhexis edge subincisionally, hooking the peripheral lens, lifting it and tilting it, getting it up out of the bag, and then crushing it with the instruments. Such a cool way to get that stuck second heminucleus that's in the subincisional space. I used to rehydrodissect. I used to viscodissect. Again, nothing wrong with those techniques. It just takes extra steps, extra time. But instead, I'm just using the chopper right there. I have it there. Lift it, get under it. I'm used to using the chopper to hook the lens contra-incisionally, but why not do it subincisionally? It's just a brilliant way to loosen the lens up. Using the chopper, I'm able to hook up the peripheral lens in the subincisional space. Again, very efficient way without damaging the zonules. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start subincisionally, removing the lens material from anterior to posterior. By doing it this way, you get the cleanest removal of the cortex. But you can see here, this cortex was really stubborn. It was really stuck and adherent to the capsular bag, and no wonder I had trouble spinning it. And you can see I'm polishing, and there's quite a bit of puckering of the posterior capsule, which again suggests there's weak zonule. So again, it's a combination of very fluffy epinuclear material and the cheese wires when you're trying to spin. You also have some loose zonules, and so when you're trying to rotate, the zonules just kind of stretch, and it doesn't hold the capsular bag in place, and therefore as you're trying to spin the lens, it doesn't really spin effectively. But again, this is the point. You should have other techniques in how to disassemble the lens without having to rotate the lens. Pulsing BSS into subincisional capsule fornix, and there was some material that came out. Turning off the infusion and then pushing cohesive viscoelastic to fill the bag. Switching to the sweep and sweeping under the rexus edge on the left side first. And then the right side. Removing all the lens epithelial cells, you can see there's some material that's coming out. Again, this is such an easy way to disassemble the lens. Again, utilizing your instruments to pull the lens pieces up out of the bag, whether it's contra-incisionally or subincisionally in this case. Delivering the single piece acrylic lens into the capsular bag, going in with irrigation off, activating irrigation, disengaging the haptics off the optic, getting underneath the lens, tilting it, removing the viscoelastic from within the bag, repositing the optic back down, polishing underneath the rexus edge in polish mode, removing all the viscoelastic in the anterior chamber, and then I'll hydrate my incision. So again, my technique of performing double chop and cross chop depends upon hooking the peripheral lens contra-incisionally with the chopper, and then hooking the subincisional lens with the phaco tip, tilting it vertically, and being able to stab the lens and then crushing it completely in half. There's no translational movement, there's no tilting of the lens, there's no stress on the zonules. That's the point. People were skeptical because they thought there's stress on the zonules. That doesn't happen. And then I perform cross chop, which is essentially placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centered toward the phaco tip, crushing the lens in half against the phaco tip, like the phaco tip is a chopping block, and that is a cross chop. You're able to utilize that same maneuver over and over and over again to disassemble the lens pieces in front of you. And then you had this big old subincisional heminucleus, which didn't want to come out. You could hydrodissect again, sure. You can viscodissect. You can do a bunch of other things. But what I did was I hooked the lens subincisionally out with the chopper. In addition to hooking the lens contra-incisionally, now I'm able to hook the lens subincisionally, pop the lens up out of the bag. Super easy, a very efficient way to get that stuck lens piece up out of the bag. Once I lift it up, I'm able to get underneath it with the phaco tip, and once I get underneath it with the phaco tip, I'm able to fracture the lens completely in half, and then using mechanical forces to crush the lens pieces into smaller pieces, and that's it. And then once the lens pieces are out, you go back to the INA, which was very efficient. Again, this patient had some loose zonules, stubborn lens, which was soft, and when you try to spin it, it cheese wired. Why do that? Why put yourself through all that trouble trying to spin the lens? I've seen cases where surgeons just kind of push and just really force the issue, and they're really torquing, putting a lot of stress on the zonules, and they're just, you can see the zonules being stretched and pulled. It's really not the best way to do cataract surgery. Don't damage the zonules that way. If you do that, guess what? I'm not surprised we have patients come in with late lens dislocation. You got to wonder if you doing the surgery in that way and stressing the zonules is leading to late dislocation. Don't do that. If you have a stuck subincisional lens, use the chopper. Use your instruments to pull lens pieces up out of the bag. This is why I feel like this is the best way to do cataract surgery, in particular when you have a subincisional heminucleus that won't spin. So I hope this was helpful to you, and I thank you for your attention.